Imagine a 20-year-old final year med student like us coming to you with a complaint of unilateral throbbing kind of a headache with extreme sensitivity to light, to sound, nausea. He is seeing silvery zigzag lines and you will ask him, do you have any fever? He says no. Do you have any neck stiffness? He says no. Are your symptoms sudden in onset? You've ruled out these three things: fever, neck stiffness and sudden onset. You can rule out two very important and very dangerous causes of headache: subarachnoid hemorrhage and meningitis. All in all, our chief complaints point towards a migraine. You take this patient to your examination table and you look for his neurological examination. It's completely normal. Now, I check for his BP. He's mildly elevated. That is obviously because he's in so much pain. Look at the general appearance of the patient. He looks very distressed and he has an aversion to light and sound. What will you do? We'll send him for a non-contrast CT of the head in case you want to rule out an intracranial bleed, a hemorrhage, or a space-occupying lesion. You may also want to do an MRI brain, rule out any kind of structural abnormalities. And if you want to rule out a condition called temporal arteritis, which is normally seen in elderly people, not over here, also send for an ESR and just CRP levels. So what happens in migraine? Why do migraines hurt so bad? If you've had one, you would know what I'm talking about. Sometimes what happens is you have a genetic predisposition. You see those neurons inside the brain. They have ion channels in the neurons, which makes the neurons excitable and your impulses are transmitted in their normal fashion. But if these ion channels become hyperactive because of some mutation, what mutations? You have mutations in the calcium channels and the ATP channels. Now if that happens, your neurons will be hyperexcitable. Now what happens when your neurons are hyperexcitable? They are going to conduct impulses at a rapid rate, them in a depolarizing wave all over the cortex that is going to spread. What happens is when you have certain triggers like stress, hormones, or light, this activates those hyperexcitable neurons because of the ion channel mutations there. The impulse travels in a depolarizing fashion as an entire wave spreading throughout the cortex. Because of this abnormal cortical excitation, there is going to be overactivity of the ATPase pump. You know what the ATPase pump does, right? If sodium and calcium is coming in, potassium is going out and accumulates outside extracellularly. When this happens, this releases a neurotransmitter called glutamate, which you know to be an excitatory neurotransmitter. Now this glutamate release is going to excite all your neurons. This ATPase pump, because of overactivity, is going to exhaust itself and there is going to be a transient neuronal silencing. These neurons are going to go silent for a while and as a result, you will experience certain symptoms like tingling and visual loss. This is known as aura. Aura is something I like to remember with a mnemonic. We are so lamba. Visual symptoms. This is for retinal symptoms, sensory, limbic, not sure. Motor symptoms and brainstem symptoms. Symptoms are something known as posterior circulation symptoms, which include ataxia, diplopia, all of that. Typically, you will see silvery zigzag lines. Because of this transient neuronal silencing, there will be a decrease in cerebral blood flow for a while. So the trigeminal system gets activated because of this decreased cerebral blood flow. You're done for. You're gonna have a lot of pain now. It is going to activate the trigeminal afferent nerve fibers, which are present in the meninges. There will be release of certain substances from these afferent nerve fibers. What substances? Substances include CGRP, substance P, and neurokinin 8. They cause vasodilation of the meningeal blood vessels, plasma protein extravasation, neurogenic inflammation. Because of that vasodilation, there is going to be a typical pain. There is a repetitive nociception input. There is going to be hyperexcitability of the neurons in the brainstem and thalamus. Because of this, there is going to be something known as allodynia. Basically, increased perception of pain. One more thing you need to know in this entire process are the neurotransmitters that are involved here. Normally, if you have good serotonin levels in your body, your trigeminal pathway is going to be inhibited. As a result, you will have less perception of pain because of less vasodilation. But in case your serotonin drops, as in the case of migraine, you will have increased inflammation, increased vasodilation, and increased pain. This is the central sensitization in a case of migraine. Because there is a decreased inhibition of the brainstem since the norepinephrine is decreased in migraine. Dopamine in migraine increases, which is going to lead to a sensation of nausea, vomiting, and yawning. This is collectively known as the state of prodrome, which actually precedes everything that happens here. Glutamate increases, you will obviously have an increased excitation of the neurons, something known as excitotoxicity, because anything is toxic if excess. It's also known as the cortical spreading depression of Leo. It spreads at the rate of 3 mm per minute GABA is an inhibitory neurotransmitter. If it decreases, there will be less inhibition of the cortex, which will again facilitate the process. And now, piss me off. Okay, so this is for paracetamol, ibuprofen, sumatriptan, metoclopramide, and oxygen. Migraine. If the patient is coming to you with a very severe migraine attack, this is what you will give to them. And if the patient is prone to migraines, you know there's going to be a future migraine. Pat the future migraine away. So you'll give them propranolol, give them amitriptyline, and you'll give them dopamine. So this was about migraine.